Welcome to the 2021 Outpatient E&M Changes presentation. This presentation will guide you through the new guidelines that are effective January 1st, 2021. What you need to know. The changes are specific to the outpatient E&M codes only. What are the changes? The history and exam documentation are no longer counted towards calculating the level of service, but a visit pertinent history and exam should be documented. The progress note is still a source of information, so it is important to provide pertinent information for anyone reviewing the notes. The level of service is now determined based on either time or medical decision-making only. And there are new prolonged service codes specific to outpatient services. The new guidelines apply only to the outpatient range of codes. These would be 99202 to 99205 for new patient visits, and 99212 to 99215 for established patient visits. Code 99201 has been deleted due to underutilization. 99211 is still effective but does not require the physician's presence. This code is used for incident to services such as a nurse visit done by order of the physician. For example, blood pressure checks, weight checks, etc. What do these changes do? The new guidelines are designed to ease the burden of documentation for the providers. It also eliminates the need to count bullet points for the history, review systems, past family social history, and the exam. It puts the focus on the medical necessity and medical decision-making for the visit, and it provides new guidelines in determining medical necessity. One important detail, the time requirements for some levels of service have been changed. Some changes in documentation requirements. The chief complaint no longer needs to be re-entered by the provider. The provider can indicate the chief complaint was reviewed and agreed with, or add, remove, update as appropriate based on the conversation with the patient. Document a medically appropriate history and exam for the visit. The performance of the history and exam should be done when clinically appropriate. So, how does this work? The overarching criteria on selecting a level of service has always been and continues to be medical necessity. When selecting the level of service, medical necessity should be kept in mind. Medical necessity is defined as the requirement that a service is reasonable and necessary. This is met when a service is furnished in accordance with the accepted standards of medical practice for the diagnosis or treatment of the patient's condition. This definition can be found in the Medicare Program Integrity Manuals, Chapter 3, Section 6.2.2. Selecting a code based on medical necessity and decision-making. There are 4 levels of MDM: minimal straightforward, low, moderate, and high. Medical decision-making. There are 3 categories in determining the level for medical decision-making. Category A, labeled number of complexity of problems addressed at the encounter, equates to the acuity of the problem. Count only the diagnosis being addressed during the encounter. Category B, labeled amount and/or complexity of data to be reviewed and/or analyzed, equates to the data and discussion reviewed done at that visit. This should focus on visit-relevant tests or data. Category C, labeled risk of complications and/or morbidity or mortality of patient management, equates to patient management, includes other problems and/or treatments. You need to meet the same level in 2 of these 3 categories to determine the level of service. More on this later. To determine the level for category A, consider the problems addressed. A problem has now been defined as a disease, condition, illness, injury, symptom, sign, finding, complaint, and/or matter addressed during the visit, with or without a diagnosis being established at the time of visit. Level 2, which is straightforward or minimal, is a problem that is self-limited. Level 3, which is stable, is a problem that's uncomplicated and/or a single problem. Level 4, which is moderate, is multiple problems or a patient that is significantly ill. Level 5, which is high, is a very ill patient. As a side note, these categories can be referenced to help determine medical necessity. This is a table guide for category A to assist in determining the level. Before we go into category B, full disclosure, this category can be a bit confusing. Hold tight and we will get through it. To determine the level for category B, you need to consider the amount and/or complexity of the data to be viewed and or analyzed. These are things like lab tests, radiology services, medical services such as EKGs, echoes, nerve testing, hearing and vision services, and or discussion with other providers. There are 3 subcategories to category B. Subcategory 1 is tests ordered, documented and or reviewed, or discussions with independent historians. Each unique test can be counted to help determine the level of service. A unique test is defined as any service that has its own CPT code. For example, a CPC has 8 separate elements to it. Because all 8 elements are bundled into the CPC, it can only be counted as one unique test rather than 8 unique services. Subcategory 2 is independent interpretation of tests not reported separately by the billing provider. For example, if you order, perform, interpret, and bill for an EKG in your office, it does not count in this category. But if the patient brings in the tracing from a facility or other provider, and you review and interpret the tracing yourself without billing for it, you can count it in this category. Be sure to document that you reviewed the tracing and document your interpretation. Subcategory 3 is discussion of management test interpretations with an external physician or other qualified healthcare provider, appropriate source that is not reported separately by the provider. So discussing this test with your partner or other providers in your practice does not count. However, if you discuss this test with the performing provider who is outside of your own practice, you can count it in this category. Selecting your level for category B, amount and or complexity of data to be reviewed and analyzed. For level 2, which is straightforward or minimal, you need minimal or no data. For level 3, which is low, you need items out of one category, 2 documents or an independent historian or independent interpretation. Level 4, which is moderate, requires elements out of one category. You can count 3 items between tests and documents or an independent historian or interpretation of a test or discussion with a physician or outside provider. For level 5, you need to meet 2 categories. The same concept of level 4, but you need to meet 2 of those categories. This is an at-a-glance look at the categories and each of the items in the categories for level 4 and level 5. This is another decision table designed by NAMIS. T&D stands for tests and data. IHX equals independent historian. Interp equals independent interpretation of tests. DISC equals discussion of management or test interpretation. I warned you, this category gets confusing. The good news is you only need 2 out of the 3 categories. So if you meet your level for category A and C, you can ignore category B. More on this later. To determine the level for category C, consider the risk of complications and or morbidity or mortality of the patient management. A level 2 equates to minimal risk of mortality from additional diagnostic testing or treatment. A level 3 equates to low risk of morbidity from additional diagnostic testing or treatment. A level 4 equates to moderate risk of morbidity from additional diagnostic testing or treatment. Some examples of such treatment include prescription drug management, decision regarding minor surgery with identified patient or procedure risk factors, decision regarding elective major surgery without identified patient or procedure risk factors, and clarified this year, diagnosis or treatment significantly limited by social determinants of health. For level 5, it equates to high risk of morbidity from additional diagnostic testing or treatment. Some examples are drug therapy requiring intensive monitoring for toxicity, decision regarding elective major surgery with identified patient or procedure risk factors, decision regarding emergency major surgery, discussion regarding hospitalization, and decision not to resuscitate or de-escalate care because of poor prognosis. All of the considerations should be determined at the visit and associated with the patient's problems and or treatments. Consideration can be given to possible management options selected as well as those considered but not selected, and risk associated with social determinants of health. Social determinants of health are defined as conditions in the environment in which people are born, live, learn, work, play, worship, and age that affects a wide range of health, functioning, and quality of life outcomes and risks. These include economic stability, education, health and healthcare, neighborhood and built environment, and social community context. Be sure to document these. This is a table of risk of complications and or morbidity or mortality of patient management and includes some problems and treatments. The overall MDM is determined by calculating the level of each of these three categories, category A, B, and C. Select the two categories with the highest level. Of the two categories with the highest level, the lowest of those two levels will be your MDM. This is an example of that. In category A, your decision was high. In category B, you had none or minimal. And in category C, you had a moderate level of decision making. Overall, you have a moderate level or level 4. Here's where you can see that if we meet our levels with category A and C, we can completely ignore category B. If your patient has 2 or more stable chronic illnesses, such as diabetes, hypertension, hyperlipidemia, asthma, etc., and you manage the medications, you meet the level 4 without having to consider any data from category B. Coding based on time. If you choose to code based on time rather than MDM, that is an option. But again, remember that the overarching criteria is medical necessity. There is a minimum time requirement, and all time counted must be spent on the date of service. Accumulate the total time spent on the date of service for the services performed. This can include face-to-face and non-face-to-face time. The old requirement of greater than 50% of the time spent in counseling and coordinating care no longer applies. Time must be provider attending time and does not count resident time. These are the services that can be used to count time. Again, medical necessity must be evident for the documented time spent. These are the services that you cannot count towards time. And any time spent doing these activities must be taken out of the total time spent with the patient. CPT now gives a range of typical times for each level of service. When coding based on time, document the total time spent with the patient. Do not document the range of time. Minimum time for a new patient is 15 minutes. If less than 15 minutes is spent with the patient, then code based on MDM. The minimum time for an established patient is 10 minutes. If less than 10 minutes is spent, code based on MDM. The times for 99213 and 2114 have been increased for calendar year 2021 and forward. Due to the changes in calculating time, there are new prolonged service add-on codes. These are to be used with only the outpatient E&M level of service codes 99205 and 99215. They cannot be used with any other code. Prolonged service codes cannot be used if less than 15 minutes is spent with the patient over and above the maximum time for the 99205 or the 99215. This is a very important fact. Please be aware, CMS and AMA have different calculations for time requirements for the outpatient office visits. This table shows the time requirements for Medicare and Medicare replacement plans and for other private payers. If a patient has dual insurance, it is safest to follow the Medicare table. The remaining slides list the definitions of terms used for medical decision-making as defined by the American Medical Association. Some have examples for clarification. Please read through and familiarize yourself with these terms as they play a vital role in selecting the appropriate level of service for the visit. Here are some resources and reference tools for you to go to. Much of this presentation was pulled from these resources. Thank you for allowing us to present this information to you. Please do not hesitate to reach out to us for any concerns you may have.